Welcome to the Maternity NCLEX Fast Track course. If you're short on time, this course is for you. Master key maternity concepts quickly and efficiently. Let's get started. Blood pressure monitoring in pregnancy is crucial, and nurses should closely observe pregnant clients' blood pressure levels. Normally, blood pressure decreases gradually during the second trimester and returns to pre-pregnancy levels in the third trimester. However, an increase of more than 15 millimeters of mercury in diastolic BP or more than 30 millimeters of mercury in systolic BP before 32 weeks is concerning, as it may indicate gestational hypertension or preeclampsia. When managing syphilis during pregnancy, the gold standard treatment is an intramuscular injection of benzathine penicillin G. If a patient is allergic to penicillin, desensitization is necessary, as penicillin is the only safe and effective option for treating syphilis during pregnancy. Failure to treat syphilis significantly increases the risk of miscarriage, stillbirth, preterm birth, and congenital syphilis in the newborn. For estimating the due date, Nagel's rule can be applied using two methods. The first method involves taking the first day of the last menstrual period, LMP, adding 9 months, and then adding 7 days. The second method requires subtracting 3 months from the first day of the LMP and then adding 7 days. However, it is essential to confirm the estimated due date with an ultrasound, particularly in cases of irregular menstrual cycles. Weight gain recommendations during pregnancy vary depending on the trimester and pre-pregnancy BMI. In the first trimester, the expected weight gain is approximately 1 pound per month, totaling around 3 to 4 pounds. During the second and third trimesters, the recommended weight gain is about 1 pound per week. The total weight gain should be 28 to 40 pounds for underweight women, 25 to 35 pounds for those with a normal BMI, 15 to 25 pounds for overweight women, and 11 to 20 pounds for obese women. A quick formula to estimate ideal weight gain is week of gestation minus 9. Constipation is a common issue during pregnancy due to increased progesterone levels, which decrease gastric motility, and iron supplements, which may contribute to constipation. Management strategies include consuming a high-fiber diet with whole grains, fruits, and vegetables, increasing fluid intake, engaging in regular exercise, and using bulk-forming fiber supplements such as psyllium. However, pregnant individuals should avoid tea, soda, and caffeine as they can worsen dehydration, and they should not take iron supplements with dairy products as this reduces iron absorption. Regarding alcohol consumption during pregnancy, no amount of alcohol is considered safe. Exposure to alcohol increases the risk of fetal alcohol syndrome, FAS, which can lead to microcephaly, developmental delays, facial abnormalities, and cognitive impairment. Nurses should educate clients to stop drinking before conception to prevent teratogenic effects. Oligohydramnios, defined as an amniotic fluid index AFI of less than 5 centimeters, can result from placental insufficiency, premature rupture of membranes, PROM, or fetal renal abnormalities such as renal agenesis or Potter syndrome. This condition can lead to complications, including umbilical cord compression, which causes variable decelerations on fetal heart rate monitoring, pulmonary hypoplasia if oligohydramnios occurs early, and restricted fetal movement, which may result in limb contractures. Diagnosis is confirmed via ultrasound, and management strategies include amnioinfusion in cases of fetal distress, close monitoring of fetal growth and well-being, and hydration therapy using oral or IV fluids for mild cases. Anemia in pregnancy is a common complication, often resulting from iron deficiency. The diagnostic criteria include hemoglobin levels below 11 grams per deciliter in the first and third trimesters or below 10.5 grams per deciliter in the second trimester, while a hematocrit level below 33% also indicates anemia. One notable symptom associated with iron deficiency anemia is pica, which refers to an abnormal craving for non-nutritive substances such as ice, clay, or starch. To diagnose anemia, healthcare providers order hemoglobin and hematocrit tests as a screening measure. Management involves iron supplementation, which is best absorbed when taken with vitamin C. Additionally, consuming iron-rich foods such as red meat, poultry, fish, leafy green vegetables, beans, lentils, and iron-fortified cereals is essential. However, calcium-rich foods like milk and cheese should be avoided around the time of iron intake, as they can inhibit absorption. Proper nutrition during pregnancy is crucial, with essential nutrients playing a key role in maternal and fetal health. Folic acid, found in leafy greens, citrus fruits, beans, and fortified cereals, helps prevent neural tube defects. Iron, which prevents anemia, is abundant in red meat, spinach, legumes, and fortified grains. Whole grains such as brown rice, whole wheat bread, and oats provide energy and aid digestion, while omega-3 fatty acids from sources like salmon, flax seeds, and walnuts support fetal brain development. Conversely, certain foods should be avoided due to potential risks. Unpasteurized dairy poses a listeria risk, while raw or undercooked meat, eggs, and fish increase the chances of salmonella and toxoplasmosis infections. Deli meats and hot dogs should be reheated to steaming to eliminate the risk of listeria. High mercury fish, including shark, swordfish, king mackerel, and tilefish, should also be avoided, along with liver, as excessive vitamin A intake can lead to birth defects. Hypertensive disorders in pregnancy require careful monitoring, as they pose risks to both the mother and baby. Gestational hypertension is characterized by new-onset blood pressure of 140/90 millimeters of mercury or higher after 20 weeks of gestation without proteinuria or end organ damage. Preeclampsia, on the other hand, presents with elevated blood pressure along with proteinuria or signs of organ dysfunction such as elevated liver enzymes and renal impairment. Symptoms include headaches, facial swelling, and visual disturbances like blurry vision and scotomas. If preeclampsia progresses to eclampsia, which is marked by seizures, it becomes a medical emergency, requiring magnesium sulfate to prevent further seizures. Another serious condition in pregnancy is disseminated intravascular coagulation, DIC, which is associated with high risk factors such as placental abruption, fetal demise, severe preeclampsia, and amniotic fluid embolism. The underlying pathophysiology involves widespread clotting that depletes clotting factors, leading to uncontrolled bleeding. Clinical manifestations include excessive bleeding at IV sites, gums, and surgical wounds, as well as internal bleeding indicated by petechiae, ecchymosis, and hematuria. Additionally, patients may exhibit shock symptoms such as hypotension and tachycardia. Management involves obtaining baseline coagulation labs, including PT, a PTT, fibrinogen, platelets, and D-dimer levels, along with the administration of blood products such as fresh frozen plasma and platelets. Ectopic pregnancy, where a fertilized egg implants outside the uterus, most commonly in the fallopian tube, is another critical condition requiring prompt intervention. Symptoms include severe unilateral abdominal or pelvic pain, as well as referred shoulder pain due to blood irritating the diaphragm. If rupture occurs, patients may develop hypotension, dizziness, and tachycardia, necessitating emergency surgery. In cases where the ectopic pregnancy is unruptured and there is no fetal cardiac activity, methotrexate is administered as a medical management option. However, a ruptured ectopic pregnancy requires emergency laparoscopic surgery to prevent further complications. Fetal heart rate monitoring is essential for assessing fetal well-being. It can be detected via Doppler as early as 10 to 12 weeks of gestation, with a normal fetal heart rate ranging between 110 and 160 beats per minute. Abnormal patterns indicate potential complications such as bradycardia, defined as a fetal heart rate below 110 beats per minute, which may be caused by fetal hypoxia, maternal hypotension, or umbilical cord compression. Conversely, tachycardia, characterized by a fetal heart rate exceeding 160 beats per minute, can result from maternal fever, infection, or fetal distress. Monitoring and timely interventions are crucial to ensuring a healthy pregnancy outcome. Placenta abruptio presents with a sudden onset of vaginal bleeding, severe abdominal pain, uterine tenderness, and hypertonic contractions. This condition occurs due to the premature separation of the placenta from the uterine wall, leading to hemorrhage, fetal distress, and maternal complications. Several risk factors contribute to placenta abruptio, including hypertension, preeclampsia, trauma, smoking, cocaine use, prior abruption, and advanced maternal age. The complications can be severe, with risks such as disseminated intravascular coagulation, DIC, fetal hypoxia, and maternal hemorrhagic shock. Management involves continuous fetal monitoring, fluids, and blood transfusion if necessary. In cases of fetal distress or significant hemorrhage, an emergency C-section is required. In contrast, placenta previa is characterized by painless vaginal bleeding, typically occurring in the second or third trimester. Diagnosis is confirmed through ultrasound, which reveals the placenta covering or near the cervical os. Risk factors for placenta previa include a history of prior C-section, multiple gestations, uterine scarring, smoking, and advanced maternal age. Management strategies focus on pelvic rest, which includes avoiding douching, vaginal exams, and intercourse. Additionally, large-bore intravenous access is essential for potential fluid resuscitation, and serial ultrasounds are conducted to monitor placenta position. A C-section is planned after 36 weeks, before the onset of labor. A key nursing tip to remember is that a vaginal exam should never be performed in a patient with suspected placenta previa due to the risk of severe hemorrhage. Preterm birth, defined as birth before 37 weeks of gestation, has multiple risk factors, with the most significant being a history of prior preterm birth. Other contributing factors include previous cervical surgery such as cone biopsy or LEEP procedure, tobacco, alcohol, or drug use, and maternal age below 17 or above 35 years. Additionally, Black race is associated with a higher risk due to health disparities and an increased inflammatory response. Infections such as urinary tract infections, UTIs, bacterial vaginosis, and chorioamnionitis, as well as periodontal disease, have been linked to systemic inflammation and preterm labor. Multiple gestations, including twins or triplets, also increase the risk. Management strategies include progesterone therapy to prevent preterm labor in high-risk patients, cervical cerclage for cervical incompetence, defined as less than 25 millimeters, and corticosteroids like betamethasone to promote fetal lung maturity if preterm birth is imminent. Furthermore, tocolytics such as nifedipine, indomethacin, and terbutaline are used to delay labor. Regarding vaccines in pregnancy, certain vaccines are safe and recommended, while others are contraindicated. Safe vaccines include the inactivated influenza vaccine, flu shot, and the TDAP vaccine, which is administered between 27 and 36 weeks to provide passive immunity to the newborn. However, live vaccines should be avoided during pregnancy, including the influenza nasal spray, MMR, measles, mumps, rubella, and varicella vaccines. Additionally, pregnancy should be avoided for at least 4 weeks after receiving a live vaccine. Hyperemesis gravidarum, or severe morning sickness, is characterized by persistent nausea and vomiting, leading to dehydration and weight loss. Clinical features include weight loss exceeding 5% of pre-pregnancy weight, and signs of dehydration such as poor skin turgor, dry mucous membranes, tachycardia, and hypotension. Electrolyte imbalances are common, with findings such as hypokalemia, hyponatremia, and ketonuria due to starvation and fat breakdown. Additionally, increased urine-specific gravity is noted due to dehydration, while metabolic alkalosis occurs as a result of excessive vomiting and gastric acid loss. Management involves IV fluid administration using normal saline or lactated Ringer's solution with electrolyte replacement. The first-line treatment includes vitamin B6 combined with doxylamine, while antiemetics such as ondansetron, Zofran, metoclopramide, and promethazine may also be used. In cases of prolonged vomiting, thiamine supplementation is necessary to prevent Wernicke encephalopathy. Prenatal teaching is essential for ensuring a healthy pregnancy, and it includes guidance on healthcare provider HCP visits, laboratory values, common conditions, and necessary interventions. Regular prenatal visits follow a structured schedule, once a month until week 28, then every 2 weeks until week 37, and weekly from week 37 until delivery. If labor has not started by week 42, the healthcare team considers induction or a cesarean section. Alongside these visits, monitoring hemoglobin levels is crucial, as normal values vary across trimesters. During the first trimester, hemoglobin can be as low as 11 grams per deciliter, while in the second and third trimesters, levels may drop to 10.5 grams per deciliter due to hemodilution. However, if levels fall below 10 grams per deciliter, anemia is diagnosed, necessitating iron supplementation. Another important condition in pregnancy is intrahepatic cholestasis of pregnancy, ICP, a liver disorder that causes intense itching, particularly on the hand, and feet, which worsens at night. Though it presents without a rash, ICP increases the risk of fetal distress, preterm birth, and stillbirth. Because of these risks, it requires close monitoring of bile acid levels. Management includes administering ursodeoxycholic acid, UDCA, to reduce bile acids and performing frequent fetal assessments such as non-stress tests, NSTIA, and biophysical profiles, BPP. In severe cases, early delivery at 37 weeks is recommended. Another essential prenatal test is the indirect Coombs test, which screens for Rh sensitization in Rh-negative mothers such as those with an O-negative blood type. If maternal and fetal blood mix due to trauma, amniocentesis, abortion, ectopic pregnancy, or delivery, an Rh-negative mother may develop antibodies against an Rh-positive fetus. This can lead to hemolytic disease of the newborn, HDN. To prevent this, Rh immune globulin, RhoGAM, is administered at 28 weeks of gestation, within 72 hours postpartum if the newborn is Rh positive, and after any event that may cause fetal-maternal blood mixing. Nutritional support is also a key aspect of prenatal care, with folic acid, vitamin B9, playing a vital role in preventing neural tube defects, NTDs, such as spina bifida and anencephaly. Women planning pregnancy and those in the first trimester should consume 400 to 800 micrograms of folic acid daily. This can be obtained from fortified grains such as cereal, bread, and pasta, as well as leafy green vegetables like spinach, kale, and asparagus. Other good sources include legumes like lentils, chickpeas, and black beans, along with citrus fruits such as oranges and papaya. In addition to these key topics, understanding fundal height measurements is helpful in assessing fetal growth. By 12 weeks, the fundus is just above the pubic symphysis. At 20 weeks, it reaches the umbilicus, and after 20 weeks, it typically grows about 1 centimeter per week, with a normal variation of plus or minus 2 centimeters. Another important indicator of fetal well-being is kick counts, where expecting mothers should feel at least 10 fetal movements within 2 hours. If fewer than 10 kicks are detected, drinking cold water, resting, and reassessing may help. However, if fetal movements remain reduced, immediate contact with the healthcare provider is necessary. Finally, recognizing danger signs in pregnancy is critical for early intervention. Symptoms requiring immediate evaluation include severe headache, vision changes, epigastric pain, or right upper quadrant pain, which may indicate preeclampsia. Painless vaginal bleeding could suggest placenta previa, while a sudden gush of fluid before 37 weeks may signal preterm premature rupture of membranes, PP-ROM. Additionally, decreased fetal movements necessitate urgent fetal monitoring to ensure the baby's well-being. By staying informed about these essential aspects of prenatal care, expectant mothers can help ensure a safe and healthy pregnancy. Measuring fundal height is an essential aspect of prenatal assessment as it helps estimate gestational age. After 20 weeks of pregnancy, the fundal height in centimeters approximately corresponds to the number of weeks pregnant. To ensure an accurate measurement, the bladder should be emptied to prevent distortion, and the client should be positioned supine with knees slightly flexed. A non-elastic measuring tape is then used to measure from the symphysis pubis to the highest point of the fundus. The position of the fundus changes with gestational age, making it a useful indicator of fetal growth. At 12 weeks, the fundus is just above the symphysis pubis, while by 16 weeks, it is midway between the symphysis pubis and the umbilicus. By 20 to 22 weeks, the fundus reaches the level of the umbilicus, and at 36 weeks, it approaches the xiphoid process. However, after 37 to 40 weeks, the fundal height may decrease slightly as the baby engages in the pelvis, a phenomenon known as lightening. In addition to fundal height, quickening, or the first fetal movement, is another milestone in pregnancy. This typically occurs around 18 to 20 weeks in primigravida, first-time pregnancies, and as early as 14 to 16 weeks in multigravida, subsequent pregnancies. Recognizing these changes helps in monitoring fetal development and maternal well-being. A crucial consideration during pregnancy is uterine displacement and the risk of supine hypotension. If a pregnant client lies flat on their back, the uterus can compress the inferior vena cava, reducing blood return to the heart and leading to hypotension, pallor, and dizziness. To prevent this, the first intervention is to tilt the client laterally, preferably to the left side. This positioning is also vital in emergency pregnancy trauma care, where lateral tilting should be done before initiating resuscitation efforts to maintain adequate perfusion to both the fetus and the mother. Medication use during pregnancy requires caution, especially with NSAIDs. In the first and second trimesters, NSAIDs are classified as Category C, meaning they should only be used if the benefits outweigh the risks. However, in the third trimester, they fall under Category D and should be avoided due to the risk of premature closure of the ductus arteriosus and oligohydramnios. Instead, acetaminophen, Tylenol, is recommended as a safer alternative for pain relief. Hypertensive disorders of pregnancy, such as preeclampsia and eclampsia, pose significant risks to both mother and baby. Preeclampsia is characterized by hypertension, blood pressure greater than 140/90, and proteinuria, greater than 300 milligrams per 24-hour urine, while eclampsia involves seizures occurring after 20 weeks of gestation. The only definitive cure is delivery. However, magnesium sulfate is used to prevent and control seizures. Its therapeutic level ranges from 4 to 7 milliequivalents per liter, 2.0 to 3.5 millimoles per liter, and deep tendon reflexes, DTRs, should be closely monitored for signs of toxicity. If magnesium toxicity occurs, calcium gluconate serves as the antidote. During a seizure, it is crucial to turn the client on their left side, maintain a patent airway, and monitor for respiratory depression, respiratory rate less than 12 per minute, and urine output less than 30 milliliters per hour, both of which may indicate magnesium toxicity. Another common pregnancy symptom is morning sickness, typically occurring in the first trimester due to increased levels of human chorionic gonadotropin, HCG, and estrogen. To alleviate nausea and vomiting, eating dry carbohydrates, such as crackers or toast, before getting out of bed, consuming high-protein snacks before bedtime, and having small frequent meals are effective strategies. Additionally, drinking cold, carbonated fluids between meals and incorporating ginger and vitamin B6-rich foods, such as nuts, seeds, and legumes, can help reduce nausea. Gestational diabetes mellitus, GDM, is another condition that requires screening between 24 to 28 weeks of pregnancy. The initial test is a 1-hour glucose tolerance test, which involves drinking a 50-gram glucose solution without the need for fasting. A normal result is less than 140 milligrams per deciliter, whereas an abnormal result greater than 140 milligrams per deciliter necessitates a 3-hour glucose tolerance test for further evaluation. If left untreated, GDM can lead to complications such as macrosomia, neonatal hypoglycemia, and respiratory distress in the newborn. Another important screening in pregnancy is for Group B streptococcus, GBS, a normal vaginal flora found in approximately 30% of women, but one that can cause neonatal sepsis and pneumonia. Testing is done between 35 to 37 weeks, and if positive, intravenous penicillin G is the preferred treatment during labor. For clients allergic to penicillin, clindamycin or vancomycin can be used as alternatives. If GBS status is unknown, empirical treatment is recommended if risk factors such as preterm labor, prolonged rupture of membranes greater than 18 hours, or maternal fever are present. Finally, pyrosis, heartburn, is a common pregnancy discomfort caused by increased progesterone, which relaxes the lower esophageal sphincter and the enlarging uterus, which pushes the stomach upward. To prevent and manage heartburn, keeping the head of the bed elevated, staying upright for 30 to 60 minutes after meals, and eating small, frequent meals can be beneficial. Additionally, avoiding large meals, fried or fatty foods, caffeine, and chocolate helps reduce symptoms. The MMR, measles, mumps, rubella vaccine, is administered only during the postpartum period if the mother was not previously vaccinated. Since it is a live vaccine, it is contraindicated during pregnancy due to its teratogenic effects. Furthermore, women who receive this vaccine should avoid pregnancy for at least 1 to 3 months after administration to prevent any potential risks to the fetus. Another important obstetric procedure is cerclage, which is placed in cases of cervical insufficiency to prevent preterm labor. After the procedure, bed rest is required only for the first few days. However, the patient should report any signs of labor, such as lower back pain, contractions, pelvic pressure, or rupture of membranes to their healthcare provider, HCP. Typically, cerclage remains in place until 36 to 37 weeks of gestation, but early removal is necessary if preterm labor or rupture of membranes occurs. In cases of spontaneous abortion, miscarriage, defined as unintentional pregnancy loss before 20 weeks of gestation, patients should follow specific nursing care instructions. They should avoid tampons and sexual intercourse for 2 weeks and report any severe pain, foul-smelling discharge, or heavy bleeding. Continuing prenatal vitamins and increasing iron intake are recommended, while ibuprofen can be taken for pain relief. Additionally, Rh immunoglobulin, Rho-GAM, is required for Rh-negative mothers to prevent isoimmunization. Certain medications, such as ACE inhibitors and ARBs, should be avoided during pregnancy due to their risk of causing fetal renal dysfunction and congenital defects. Moreover, laboratory values like WBC count tend to be normally elevated during pregnancy even in the absence of infection, which should be considered when interpreting lab results. During labor, the phases of labor are categorized into 3 stages. The latent phase, 0 to 3 centimeters dilation, involves mild, irregular contractions, and the mother is generally comfortable. As labor progresses to the active phase, 4 to 7 centimeters dilation, contractions become stronger and more regular, occurring every 3 to 5 minutes, often requiring pain management such as epidural administration. The transition phase, 8 to 10 centimeter dilation, is characterized by intense contractions every 1 to 2 minutes, increased pressure, and the urge to push. To induce labor or prevent postpartum hemorrhage, Oxytocin, Pitocin is commonly used, but it requires continuous fetal and maternal monitoring due to its potential risks. These include uterine hyperstimulation, contractions lasting more than 90 seconds or occurring less than 2 minutes apart, abnormal fetal heart rate patterns such as bradycardia and decelerations, and increased risks for emergency C-section, placental abruption, or uterine rupture. Additionally, oxytocin has antidiuretic effects, which can lead to water intoxication. It should always be administered via a secondary IV line and should not be given with other uterotonic medications like misoprostol. On the other hand, tocolytics are used to stop labor in preterm cases. Magnesium sulfate is administered for neuroprotection and preterm labor management, but monitoring for hypermagnesemia is essential. Symptoms include decreased heart rate, blood pressure, reflexes, respiratory rate, and level of consciousness. Reflexes should be maintained at +2. If decreased, the infusion should be slowed, and if increased, the dosage should be adjusted. Another tocolytic, terbutaline, is used for short-term preterm labor management but may cause maternal tachycardia. When preterm labor occurs before 34 weeks gestation, several interventions are anticipated. IM antenatal glucocorticoids, sound drugs, are administered to mature fetal lungs, while IV antibiotics, penicillin, are given as prophylaxis for Group B streptococcus, GBS. If the pregnancy is under 32 weeks, magnesium sulfate is used for fetal neuroprotection. Importantly, artificial rupture of membranes, AROM, should be avoided to prevent umbilical cord prolapse. In cases where umbilical cord prolapse does occur, it leads to abrupt fetal heart rate deceleration, fetal bradycardia, and oxygen disruption. The priority interventions include performing a sterile vaginal exam to assess cord compression and repositioning the patient into a knee-chest or Trendelenburg position to relieve pressure on the cord. In most cases, an emergency C-section is required to ensure fetal safety. Another important consideration in labor is the mucus plug, whose expulsion is not necessarily a definitive sign of labor. To determine the likelihood of a successful vaginal delivery, the Bishop score is used with a score greater than 6 to 8 indicating better readiness for labor induction. For pain relief during the late second stage of labor, a pudendal nerve block is a highly effective option, especially when rapid relief is needed before birth. Similarly, an amniotomy, AROM, or artificial rupture of membranes is performed to induce or accelerate labor, but comes with risks such as umbilical cord prolapse and infection. Therefore, nursing actions include assessing fetal heart rate before and after the procedure, checking the characteristics of amniotic fluid, color, odor, presence of meconium, and encouraging the mother to maintain an upright sitting position. Post-procedure, shoulder dystocia is a medical emergency that occurs when the fetal shoulder becomes lodged behind the maternal symphysis pubis, preventing delivery. Immediate interventions are crucial to prevent fetal hypoxia and other complications. During such an emergency, nursing interventions include precisely documenting the times of events and verbalizing the passing time every 5 minutes to maintain awareness. Additionally, requesting extra assistance from the healthcare team ensures timely and effective management. Maneuvers such as the McRoberts maneuver, which involves flexing the maternal thighs to the abdomen and applying suprapubic pressure to dislodge the shoulder, are essential. However, fundal pressure must be strictly avoided as it may worsen the impaction. To improve fetal perfusion and oxygenation, certain steps should be taken. If fetal distress is noted, discontinuing oxytocin, Pitocin, can help mitigate further complications. Repositioning the client to the left lateral side enhances circulation while administering oxygen at 8 to 10 liters per minute. Via a non-rebreather mask ensures adequate oxygenation. Additionally, providing an IV bolus of lactated Ringer's solution or normal saline supports maternal hemodynamic stability. However, when an epidural block is used for pain management, it can inhibit the sympathetic nervous system, leading to vasodilation and potential hypotension. Therefore, monitoring for signs of lightheadedness, dizziness, nausea, or hypotension is essential. The first step in such cases is to assess the client's blood pressure. And if hypotension occurs, interventions should include intravenous fluid administration, left lateral positioning, oxygen supplementation, and notifying the provider. When administering intravenous opioids in labor, timing is critical to avoid neonatal respiratory depression. The safest window for administration is 2 to 4 hours before birth, ideally during active labor, 7 to 8 centimeter dilation, when contractions are well established. To minimize fetal exposure to the medication, opioids should be given during the peak of a contraction. Meanwhile, distinguishing between true and false labor is vital in labor assessment. True labor is characterized by regular contractions that increase in intensity, along with cervical dilation and effacement, and contractions that persist despite activity changes. In contrast, false labor involves irregular contractions, no significant cervical changes, and pain that is relieved by rest or hydration. Fetal heart rate, FHR, monitoring plays a crucial role in assessing fetal well-being. The Veal-Chop mnemonic helps interpret FHR changes. Variable decelerations indicate cord compression, requiring maternal repositioning. Early decelerations are caused by head compression and are considered normal, requiring only documentation. Accelerations signify adequate oxygenation and are reassuring, whereas late decelerations indicate placental insufficiency and necessitate immediate lie-in interventions. Left side repositioning, intravenous fluids, oxygen administration, and notifying the provider. Specific FHR patterns provide additional insights into fetal status. Acceleration, which is a temporary increase in FHR, is a reassuring sign. However, a low fetal heart rate, below 110 beats per minute, requires stopping Pitocin and implementing LION interventions, while a high fetal heart rate, above 160 beats per minute, may indicate infection, requiring maternal temperature assessment. Variability in FHR is another key factor. Low baseline variability is concerning and demands lie-in interventions, whereas high baseline variability is reassuring and should be documented. Decelerations provide further clues to fetal well-being. Early decelerations, where FHR dips before or at the beginning of contractions, are normal and require only documentation. However, variable decelerations, which indicate cord prolapse, require repositioning and possibly pushing the presenting part off the cord. The most concerning are late decelerations, which occur after the contraction onset and signal fetal distress, requiring immediate lie-in interventions. Severe fetal distress is particularly evident when late decelerations persist beyond the end of contractions, indicating uteroplacental insufficiency and compromised fetal oxygenation. In such cases, oxytocin must be stopped immediately, the client repositioned to the left lateral side, oxygen administered at 8 to 10 liters per minute. Via a face mask, an intravenous bolus of normal saline or lactated ringers given, and the provider notified without delay. A sinusoidal fetal heart rate pattern, which appears as a wave-like pattern with no variability and no response to contractions, suggests severe fetal anemia, hypoxia, or Rh incompatibility. This is an obstetric emergency requiring immediate intervention, including emergency delivery or intrauterine resuscitation. Regarding OB medications, pain medication should not be administered if birth is imminent to prevent neonatal respiratory depression. Intravenous pain medications peak within 15 to 30 minutes, so their timing is crucial to avoid complications. Lastly, surfactant is administered post-birth to neonates with immature lungs via an endotracheal tube, ET-TIA, directly into the lungs, ensuring improved respiratory function. Thank you for watching. Don't forget to subscribe for daily NCLEX lectures. See you in the next one.